Hello, everyone, and welcome to the Canadian Institute for Public Safety Research and Treatment's virtual town hall series, presented by the COVID-19 Readiness Resource Project. My name is Emily Kosick, and I'm the Knowledge Manager at CIPSRT. Our topic today is what the SARS outbreak taught us about the psychological needs of healthcare workers. Today, we're going to have a brief presentation, followed by some personal experiences of people who worked through SARS. We will then follow with a question and answer period. If you have questions, you can use the questions box to send it to us, and we'll answer as many as we can. Just a reminder that this town hall is being recorded, so if you miss something, you can watch it again later. For those of you more comfortable in French, I've placed a copy of the presentation in French only as a handout, and that is available now, so feel free to open it. CIPSRT does not have permission to share the PowerPoint presentation beyond this. Please contact the individual presenter if you have any questions. Now, let me introduce our panelists and presenter. Firstly, our panelists. By voice today, we have Scott Miller, who is a registered nurse. If you want to say hello, Scott.
Hello, everyone.
And then next, we have Dominic Guimont, who is an advanced care paramedic with Ottawa Paramedic Service. Both of them worked in Toronto during the SARS outbreak. Our presenter today is Dr. Ken Balderson, who is a consulting psychiatrist with the St. Joseph's Operational Stress Injury Clinic and an adjunct professor at Western University. Hi, Ken. So I'm going to hand it over now to Ken, who's going to do our presentation. And afterwards, we'll come back with our experiences. So Ken, to you.
So thank you, Emily. And I want to thank, first of all, CIPSRT and the organizers of this town hall series. I've watched some of the others, and they've been very informative and very interesting. And I'm honored to be included in the company of the previous presenters. So I'm going to talk today about the SARS outbreak. And all three of us, myself and the discussants, experienced the SARS outbreak in various ways. I may work at the OSI clinic now, but at that time I was an inpatient psychiatrist at St. Michael's Hospital and was director of the inpatient unit. And that hospital was treating SARS patients. And like the discussants, I was personally quarantined during SARS. So that may come up later in the discussion. Okay, now our learning objectives today, I'm going to provide some information about the context of the SARS outbreak. It was a long time ago for people who went through it, and many listening, I'm sure, won't have gone through it. I'll talk about what was similar to what's going on now with COVID-19 and also some of the important differences. I'm going to then talk about studies of what the psychological impact of SARS was on healthcare workers and what the occupational and social factors affecting that impact were, and then finally summarize briefly with lessons learned from that. Okay, SARS, severe acute respiratory syndrome. This was an outbreak rather than a pandemic. It was an emerging infectious disease, which means that this was a new illness in humans. It spread rapidly worldwide. It was one of the early examples of how global travel and global plane travel led to a rapid spread of an illness. The first cases were in Guangdong province of China in November 2002. The most affected places were in China, Singapore, Taiwan, and Toronto, Canada. And it was under control by the end of July or beginning of August 2003. What brought it under control? They were traditional public health measures: case detection, isolation, contact tracing, quarantine when needed, social distancing, and in some cases lockdown, primarily in China. In total, there were 8,098 cases and 774 deaths worldwide. Now, one thing that was different with SARS was at the beginning of the outbreak, there was very limited knowledge of what was causing it. It wasn't until May 2003 that a coronavirus was identified as the putative agent. So remember, it started in November, it was pretty much over by July, but it wasn't until May when the coronavirus was identified. And also early on, the mode of transmission was not clear. And later it was found to be droplet spread as with COVID, but through the first many months, it wasn't clear how this was being spread. And the result of this was initially there was very high infectiousness among healthcare workers in hospitals. So this slide is to help think about what healthcare workers at that time were faced with. So they knew that there was an outbreak, but it was an unknown pathogen. They knew it was highly contagious. They knew it was frequently fatal. They didn't know how it was transmitted. I'm saying they, I should be saying we. And the recommendations from experts and administrators were rapidly changing, pretty much daily, and the rationale for the changes was often not clear and not apparent. What was the situation in Ontario? So Ontario had a total of 375 cases and 44 deaths. 3 of the deaths were healthcare workers, and almost all of these cases were in Toronto. In Toronto, a woman with SARS arrived from Hong Kong on the 23rd of February. She died at home, but by that time her son had been infected. Contact with her son led to 7 more cases, and then contact with these 7 led to 45 more cases, which included 30 healthcare workers, and then the spread was from there. There were 2 waves overall in Toronto in March and May 2003. How did the hospitals react to the outbreak? They changed the way they work very drastically. They restricted physical access generally. Instead of the multiple entrances and exits that were usually available, there was only one with screening going on. Surgical procedures and outpatient visits were canceled. Non-essential workers were told to stay home, and this would include students, researchers, and many of the people working in outpatient clinics. With few exceptions, visitors were not allowed, cafeterias were closed, and healthcare workers were using gloves, gowns, eye protection, and later on N95 respirators with all patients. So what was the impact of all these changes in the hospital? So one thing was it was very isolating for healthcare workers. The hospitals were very eerie at that point. Hospitals we all think of as bustling, noisy, crowded places, and they were largely empty. Large portions of them were empty. Staff were instructed to avoid any unnecessary contact either in the hospital or out of the hospital. They were told they should not meet socially outside of the hospital. So this meant a lot of the normal social interaction, which might be a handshake, a slap on the shoulder, a touch on the arm of encouragement, as well as that was just not allowed. And also conversations within the hospital were often through barriers of protective equipment, and anyone who's worn an N95 mask for any period of time will understand how difficult that is. In addition, there was stigmatization. In the community, there was a perception that people were avoiding healthcare workers and their families. For example, Easter and Passover both occurred during the outbreak, and many families canceled and shied away from their healthcare worker family members. There was also some negative media coverage that had a negative impact on healthcare workers. There was one particular story of a nurse who was on a commuter train who later was hospitalized with SARS, and there was a lot of blaming press about that. In fairness, there was some positive press about the hard work that healthcare workers was doing, but this particular negative story had a big impact. Now, I'm going to stop briefly and just talk about what's similar and what's different. So what's similar is that both of these conditions are primarily severe acute respiratory syndromes, both caused by coronaviruses. And their names are very similar, and genetically they're quite similar as well. They both originated in China. The likely reservoir was in bats. Main transmission was by respiratory droplets. And the most severe cases characterized by respiratory disease. Older patients and those with medical comorbidities were at greater risk in both cases. So, but what's different? COVID-19 in many ways is much worse. It's more infectious. So already by February 28th, there had been 10 times as many cases and 4 times as many deaths worldwide as during all of the SARS outbreak. 81% of the people infected with COVID-19 have mild disease, but they may be infectious during that mild or apparently asymptomatic period. This was also different with SARS. If someone was sick, if someone was infectious, they were sick and clearly sick. There's a lower case fatality rate with COVID-19. It may actually be under 2% versus the 10% with SARS, but because it's much wider spread and has gotten into some places like long-term care facilities with a lot of high-risk people, the overall fatality numbers are very large. And that's why the elderly are more affected here, because it's gotten into the long-term care homes. Now the lockdowns are much more widespread. The physical distancing is not just in the hospital, but it's been everywhere. And the economic impact was significant for Toronto, but now it's huge and it's global. And that has led to a lot of pressure to ease the precautions, which was not the case during SARS. In addition, the pandemic has resulted in global shortages of personal protective equipment. There was never concern about running out of this during SARS. So turning now to the psychological impact of SARS, and most of the information from the next two slides are from studies from Dr. Robert Maunder at Mount Sinai and the Impact of SARS study, which I was involved with. And I want to acknowledge the work of Dr. Maunder and Dr. Lesh at Mount Sinai, who've really taken the lead on understanding these issues and how to apply them. So in the study, we looked at healthcare workers who had worked during SARS and compared them to comparable workers in Hamilton who were not treating SARS patients, and looked at them between 13 and 26 months after the SARS outbreak had finished. What we found was there were clinically significant levels of distress in between 1/3 and 1/2 of healthcare workers. There were higher levels of burnout, there were more depression and anxiety symptoms, and also more smoking, drinking, and problematic behavior. Interestingly and significantly, the rates of mental illness were not higher. There was not an elevated rate of depression, PTSD, or any other mental disorder. Healthcare workers who had those conditions prior to SARS often were more severely affected, but it didn't seem that SARS resulted in mental illness. But there were other impacts psychologically and on occupation. So during the same studies, we found that healthcare workers who'd gone through SARS were more likely to miss work shifts due to stress or illness. They were more likely to have decreased face-to-face contact with patients, and they were more likely to be working decreased hours. And this was understood to mean that some of them had actually changed their work in the aftermath of SARS. Now, the next few slides are going to come from some work by Samantha Brooks and colleagues from King's College London and from Public Health England. And Dr. Brooks works with the Group Responses After Disasters and Emergency project in the UK, and they've come up with a lot of very helpful research about healthcare workers and first responders in a variety of disaster situations. So what were the factors that affected the outcome? One of them was definitely occupational role. I should add that they looked at all of the studies in the literature and found 22 that were particularly relevant and then synthesized the results of that. So what role you were in was very significant. In general, nurses had the highest levels of stress, which is not surprising because they were generally the front line doing the most direct patient care. Second was, depending on the study, either doctors or other healthcare workers. Specialized training and preparedness was protective. So the better trained people were in infection control procedures, the more confident they were of their training, the less likely they were to show evidence of significant stress. Working in high-risk environments, not surprisingly, caused the largest amount of stress, whether that was a SARS specialty environment or an intensive care unit caring for SARS patients. Quarantine was one of the most significant factors. Healthcare workers who were quarantined at some point during the outbreak showed the highest risk of acute stress symptoms. They felt the most stigmatized. They were the most likely to show reluctance to return to work and also deterioration in their work performance. Job stress, this was defined differently across the 22 studies. So I'll talk a little bit about what was found to be important. The heavy workload in a hazardous environment was significant. Often people had increased patient loads, or the work was simply harder because of the PPE required. A change of work or deployment also added to stress. So someone, for example, who might be used to working with a particular team and feel comfortable and supported might be reassigned to another unit where they don't know the team, and they may not understand the workflow as well. Those increased stress. In situations where job instructions were unclear, there was more evidence of stress. Similarly, infection control policies that seemed ambiguous or were not clear. Lack of appreciation from leadership or being blamed for mistakes were also associated with more stress and negative outcomes. Conversely, healthcare workers in settings where they felt appreciated, where that was expressed, and received support around mistakes fared better. Interference with home life and fear of infecting family, this was quite important. And the most affected were actually parents, who were often very affected, very concerned about either infecting their children or themselves being infected or unable to care for their children. And stigma and being discriminated against, I gave an example of this earlier, and we'll talk more about this later, I'm sure. Okay, other occupational factors that affected outcomes. So the perceptions of safety, threat, and risk were important. So and this isn't necessarily what the actual risk is, but what one believes the risk to be. So if one perceived that one's own health at risk, was very worried about infecting friends, colleagues, or family, it was more likely to show as stress. Here, trust in equipment and the infection control procedures was protective. And the amount of worry was also correlated with the number of adverse outcomes. So for example, in hospitals where fewer staff were infected and staff overall had a good outcome, they showed less stress. If people knew that there was a colleague, for example, or another healthcare worker in the institution who became infected, then there was a lot more stress evident. Organizational support was very important, and this came in a number of ways in different settings or didn't come. So in settings where there was psychological support of some kind for the staff, especially the frontline staff, where there was reassurance that there would be adequate compensation and insurance and that people's livelihoods would not be in danger if they became infected, that relieved a lot of stress. When leadership was very responsive to feedback from the frontline staff, outcomes were better, and where team spirit was better, also less stress was evident. Friends and family support was also very important. This one was a bit complicated. As I mentioned, the hospitals discouraged people from turning to each other outside of hospital for support. And for many people in healthcare, many of their friends and relationships are with other healthcare workers. So interestingly, those who followed the instructions and felt less supported and more isolated did more poorly. I mentioned before social rejection or isolation, that many of the healthcare workers felt stigmatized, discriminated against, avoided. And the impact on life here largely refers to the impact on family that I talked about earlier. So overall, what were the lessons learned? One was that there were long-term effects of SARS. They were common, as I said, occurred in between a third and half of the healthcare workers directly involved, but generally they were subsyndromal. So they weren't meeting criteria for a full mental illness. And what this means is, in thinking about how to support workers, we shouldn't be thinking about clinical interventions like seeing a psychologist, psychiatrist, except for the most affected. But interventions should involve helping workers to adapt and building resilience. So some of the ideas that came out then, and these have been adapted and I think spread widely during the current situation, but one is minimizing and mitigating the adverse effects of the interpersonal isolation. So designing ways for people to continue to communicate, whether that's virtually or in other ways, and finding other ways of providing support from within the team and outside. There should be a focus on enhancing safety, calming, efficacy, and connectedness. And many of you will recognize this as some of the important components of psychological first aid. Time and space and expertise should be provided to foster reflection and adaptation For many doing frontline work, it's all about the tasks and what's needed right now. But when people are going through very significant life and death issues, the chance to be able to step back and talk together about that is very important. Leadership must promote trust. They need to be present. They need to show that they know what they're doing, and integrity, and they should be demonstrating that healthcare workers are valued. And their communication has to be timely, relevant, and transparent. If it's found that they were hiding something that was relevant to safety later, that really has a negative effect on trust and on psychological outcome. And finally, and not surprisingly, practical support is one of the most important things, and there's a lot of psychological benefit from the practical support. So once again, knowing that one's livelihood is not at risk, and making sure there's adequate supplies of personal protective equipment and adequate training in how to use it properly. So that's the end of my presentation. I've got a couple of slides of references there, and I look forward to the discussion.
Thanks, Ken, for your presentation. We appreciate it. I'm just going to welcome our panelists back so that we can begin on our experiences. I am going to start with Scott, who is with us over the phone. It's for him to share with us his experience in working during SARS, and in fact with having SARS himself. So Scott, if you want to go ahead.
Hello, can you hear me?
I can, yeah.
Awesome. Hi, my name is Scott Miller. I've been a registered nurse for over 30 years, and I was one of the nurses that contracted SARS. So it didn't just work there, I also ended up with the illness. So the lasting effect of SARS for myself, it's been memory loss, memory issues, and concentration issues, and also chronic fatigue. So, and many people say, well, when did you recover? And I just tell them, ask them what day it is or what time it is. It's an ongoing thing. It's never left me. During SARS, we were quarantined. I was quarantined three separate times, but they kind of all went in a row. First, when all the nurses were quarantined, we were told, you know, driving back and forth to work, that we had to wear a mask in our car, even if we were by ourselves. And that was about all the information they had for us. Then there was 10 days while I was hospitalized, and then another it was 10 days or 2 weeks afterwards, after discharged as well. I was quarantined. But during, I'll get back to some of that later. During my hospital stay, so I'm going to talk about some of the effects of the isolation. And it was a total feeling of being isolated. Like, you're in a room, you didn't know what was going on, you're coughing, had extremely high fevers. I was just sleeping all the time, and any activity, having a shower would put me to sleep for 4 hours. But when the nurses came in, and doctors, they just came in, they did the bare minimum of what they had to do. They did their job, and then they left. There was no socializing, there was no discussions, or hardly any like conversations. There's definitely no socializing. Sometimes I'd wake up from a nap and I'd find pizza or donuts that the staff had dropped off, that, you know, the different companies were giving to the hospital. But again, no real contact. I'm sorry there's no video, but so you can't see my actions. But, you know, when you looked at someone, all you could see was, you know, if you just covered up just your eyes, that's all you could see of a person. So, and there definitely was no touch as well. So, and even then, so we're isolated that way, but I was even isolated even more. Like, talking to my family on the phone was very difficult, because I'd be coughing for most of the conversation. I would be experiencing shortness of breath, and again, everything made me tired. Watching TV made me tired. Reading a magazine, it was just, everything was like that. So the next kind of part here I want to talk about is when I was quarantined at home. So we made it out of the hospital alive. Everything was wonderful. But when we were quarantined at home, we were monitored by what we called the SARS police. I don't know. They were either public health nurses, retired police, or retired firefighters, and they came by every day to make sure that I was home. So even if I was sleeping, no matter what was happening, I had to be woken up and I had to go out, and I didn't have to do a lot. I just had to wave, and they had to see me, and then I could go back to sleep or do whatever I was doing. So one day, like the firefighters and the police officers, they would just call from the car. They were pretty cool. They'd wave, and everything was fine. But one day, this kind of talks about confidentiality as well. This public health nurse came to the door, and she was dressed in full PPE. I call it a hazmat suit, but it wasn't quite a hazmat suit. Goggles, face masks, gloves, gown. And the day she arrived, it was a beautiful sunny afternoon. It must have been a weekend because my neighbors were out socializing on the street. So, I mean, we were just incensed, my wife especially. She's much more emotional than I am. So we had this number we could call, kind of like a hotline of sorts, that we could either call for information or to talk to people, or they would call us to say that the so-called SARS police were coming by. So we called them, and we made a complaint about this situation. And we don't know, that person never showed up again. She was either fired or reassigned. But during the interaction, now she didn't want to talk to me, she just had to see me, but she talked to my wife, and she actually complained that she had to go out and see all these SARS patients. So when I was, there's also like more stigma related to this situation. When I was off work for about 6 months, when I did any activity again, I'd have to go for 4 to 6 hour naps. Everything was tiring, but I eventually was able to get back to work. When I went back, I'd already been in the hospital for a little bit, and there was this group of physicians, and I went up to say hello. I knew them. I've been working there for 15 years, and one of them took a full step back from me, reached his foot way back and then kind of slid back, and can't demonstrate it, of course. And I guess it was quite reactionary on my part, but I actually walked right up to him and gave him a big hug. Probably wasn't the most appropriate thing to do, but anyway, it's everything we went through. It was just like the last kind of thing that it really upset us. Upset me. But we were experiencing these kind of reactions from family, friends, and coworkers, and my wife even got a phone call from a distant relative complaining that we had visited my grandmother, and she had visited her 2 weeks beforehand, and it was like, how dare we do that? Anyway, it was bizarre, some of the things that happened. During one of these interactions, even one of the physicians told me I was lucky to get SARS, because next time it came around, I'd be immune. And even my kids, they wouldn't even send their homework home because they thought it'd come back infected. Are we still good on time?
If you have about 30 seconds to wrap it up, Scott.
So the last thing, how I was treated by the hospital, I went back to work. I had to go back. I did a couple extra little jobs, so I went back to my unit. It was a very heavy med surg floor. I was on a modified shift, and at first I could only work 8 hours at a time, and they supplied another nurse for the 4 hours. Well, eventually the hospital took that away, and then for 2 years, I basically went through, every time I had to go home, I'd have to give a patient to each of the other nurses, and just the look in their faces were, what is he going to give me now? And that was extremely stressful. There's lots more, but we don't have much time. So thank you very much for listening. I hope that came across well.
Thank you so much for sharing your experience with us, Scott, and we certainly will have more time for more of it during the question period for sure. I am just going to turn it now over to Dominic, if you want to pop back on, Dominic. I also do want to let our everybody know that I have popped up the references again. I will show them slowly just because we did have a request to show them, and while Dominic's telling his story. Okay, go ahead, Dominic.
Hi, thanks for having me. So back in 2003, I worked in Toronto. I worked in Scarborough. One of the bases that I frequently worked was right across the street from Scarborough Grace. And it was at Scarborough Grace where I kind of learned about SARS for the first time. I'm waiting around the triage desk with my patient and the triage phone rings. So since the nurse wasn't around, I answered. I knew it was an ambulance coming in. It's an update from the paramedics. I take the update, I pass it along to the triage nurse, and that's where she went, oh, another one of that mysterious pneumonia. So she told me a little bit more about the patient they had upstairs in the ICU, his mom, this and that. Crew came in with the patient, I think was patient number 3 from that family. That was my first knowledge or experience of that. A couple days later, I worked with a different partner. He attended, if my memory is good, patient number 1 at home, the first female patient that died. I worked a full night shift with him. We had no issues, all was good. A couple days later, I decided to call for some overtime, and the scheduling while doing the, looking through my name kind of went, wait a second, you need to be on quarantine. You work with paramedic such and such. He's now sick, having attended to patient number 1. Kind of got me upset because this was 3 or 4 days after I had worked with him. And if I wouldn't have called for the overtime, who knows how I would have found out. I lived with other medics at the time and my girlfriend of the time. She's a teacher, so a little stressful on that side, but I had no signs and symptoms. I was 25, pretty healthy, so I wasn't too worried, and it was still kind of early. All was good, went back to the road. At that point, they had implemented that we had to screen ourselves every day, every morning before shift. Came in, did that, no issues. Throughout the day, visited Sunnybrook Hospital. Every hospital would screen us at the same time, or every time we'd come in. I had started to have a fever, so they promptly kicked me out, to be polite. I had to call my supervisor. I was sent home, and then I was put on quarantine for a second time. That time, I did get sick. I started having a fever, shortness of breath, different symptoms. That time I was a little more worried. Tried to isolate myself as much as I could in the house. Very few phone calls. Looking back, I'm not even sure. I don't remember who called me, to be honest. I think it was public health, just checking on me, how the symptoms were, how I was feeling. By day 5 or 6, I was lost. I had no idea. Shortness of breath. I'm not asthmatic, so I didn't really know what that was supposed to feel like. But I know I had no energy. I never got tested, never got diagnosed. I don't think it was SARS, but I'll never know. I got better after time, went back to work. I had some confirmed SARS patient that I transferred. My memory's good. Mount Sinai was the hospital we had to transfer them to. I know I was at North York General when the second wave came. Then I got quarantined a 3rd time. But by that time, there were so many paramedics involved or exposed, they called it the working quarantine. So whenever we were at work, we had to wear full PPE, even in the truck with our partner. By that time, the stigma, not necessarily at work, but more outside, we became dirty, especially with the uniform. It was easy for people to see. If I wanted to go in, get a coffee or get a snack, you know, it wasn't unheard of to be denied access. Be like, nope, sorry, paramedics, nope, don't come in here. The dry cleaner I was using told me to stop coming. He didn't want my business anymore. So that got to me. You know, you're out there trying to help people, and you know, you're the enemy. There's also the whole stress of the financial stress. You know, was this going to be sick time when I was off? Was this WSIB? Everything was not clear, or as clear as it is now with COVID. PPE wasn't something that was used regularly. Fit testing for masks was unheard of, and everything was a little bit at a time with very little knowledge. I think we're going to touch on the PPE a little bit later on, but I still remember one of my supervisors coming in one day with surgical mask and giving us the mask and be like, yeah, this should be good enough, you know. That got me so angry. You know, we didn't know what we were dealing with, and instead of being extra cautious, it was like, no, go out, this should be good, don't worry, you know. And the differences that I see now with SARS and COVID is the paramedics that I know that had got COVID came back to work. Most of them came back to work. Yeah, they didn't feel too good, but it was a lot easier for them to get through it. The paramedics that got SARS in Toronto never came back to full duty. The toll it took on their health was extreme. One of them said, you know, walking to the curb, and it would take him 3 hours to rest, to recuperate after that. You know, I think that kind of resumes it. There's a few other points that I know we're going to touch with the questions, so I'll leave it for that.
Okay, perfect. Ken, I'd like to welcome you back as well. We're going to start the question and answer period. I am going to start with more talk about those differences between working through SARS and working through COVID-19. So Scott, if you wanted to answer, what do you see as the differences between going through SARS and then going through this current pandemic?
The overall, everyone's involved. It's like with SARS, it was just really focused at the healthcare workers and maybe a few individuals. And also the amount of information that came during SARS was they'd send daily bulletins, so it was very confusing. One day you wear a mask, one day you didn't. But here it was much more, still daily bulletins, but it was a lot more straightforward. Wear a mask, and then the social distancing, and then and the messages are a little bit more consistent, even though sometimes there's still a little bit of you know, people they're wavering a little bit on the restrictions, but overall the restrictions have been the same right from the start.
Dominic, what's your
SARS,
experience? Oh, sorry, Scott.
No, I just said with SARS, we just didn't know.
Dominic, what's your experience been?
Yeah, I think that was the hardest, is just we didn't know, right? And same with the PPE. We didn't know what worked, what didn't work, what was good, you know. And I think from that, we've learned to get appropriate fit testing, proper donning and doffing, you know, putting it on, taking it off, hand washing. Back then, I didn't have too much trust in my PPE because we didn't know. Now looking back, now I trust it. I know I've seen the tests. When we do the fit testing every 2 years, I can see the results. I can see if I'm failing or passing. That's been the biggest thing, I think, is for me, the biggest change.
As a difference between SARS and COVID when it comes to mental health and the mental health field where you're supporting public safety?
Well, one of the biggest things is that a lot of mental health has moved virtual. A lot of mental health is happening on screens. In fact, I'm in my home office and haven't been in my office for several months now. And that gives us much greater reach, a much greater capacity to reach people wherever they are, without taking risks ourselves, but also without potentially putting patients at risk by asking them to come into a hospital or another setting where there could be people with infections. Did you want to follow up on that? Is there something else you'd like me to?
No, that's good. Sorry, I apologize. I just had another question coming in. So I want to just talk a little bit briefly, going back to that sense of isolation. Ken, I know you had your own experience during SARS that made you feel quite isolated. If you're willing to speak to that, that would be great.
Yeah, mine was a little bit different. So although I was working in a downtown Toronto hospital, at that time in my career, I was doing twice annual outreach trips to Nunavut and going to a small community and providing psychiatric care. And in the hospital, on our unit, we actually had 2 negative pressure isolation rooms. Those weren't common on psych units at that time, so we had 2 patients under investigation. So my trip had been scheduled for a long time. I checked it out with the chief, the infection control people in the hospital, with public health in Iqaluit. They said, yeah, come on up. So I went up to Iqaluit and immediately came down with a fever. So then there was a concern, and you've seen similar concerns in the media now about what would happen if COVID got into a small isolated community, which didn't have ICU capacity and so on. So those were the concerns. It actually made some of the national news about, did a Toronto doctor bring SARS to Nunavut? So I was put in isolation. Unfortunately, I wasn't that sick, and it was pretty quickly clear, but I had to be isolated for several days. And I also had to be hidden because the press were looking for me. And then when I came out, there were certainly a number of negative comments about potentially having put people at risk in the community that I received.
I have a question asking, based on your, oh, can you hear me?
Yeah, we're
Yes,
just missing the first part.
Sorry about that,
Yep,
guys. Probably internet dropping. So we did have a question coming in. They would like to know if, based on your experiences, you have any recommendations to frontline healthcare workers or first responders that could be helpful during COVID-19 to help make their jobs or lives easier while they're going through this. So I'm going to start with Scott. If you have any thoughts on how your experience is, what you think you could recommend to make things easier.
Well, just basically trust the PPE, and if they say one day, oh, you don't need it today, just wear it. I mean, that's from SARS. I mean, I think everyone's going to wear it now, but from that time they were saying like one day don't wear it, next day wear it. Nowadays I think we would just wear it, and I think it'd be mandated anyway. But I don't know. I tend not to worry about things and just try to trust my own knowledge and my own, practices, hand washing, donning and doffing, and then just do your job, I guess. I don't know if that's helpful or not. Dominic, I guess you can answer that.
Yeah, I would say the same. Trust your PPE. For me, SARS, when I came from Toronto to Ottawa, I would put N95s and different PPE a lot more often than some of my colleagues. And sometimes I'd get weird looks, but I'm like, I'm not going through SARS again. I lived through this. I'm not doing it again. Trust it. Trust the process. Like I've always said before, more for the first responders. It's one call at a time, right? You do one call, you put your PPE on, you take it off properly, and that's the best you can do.
Okay, so I certainly echo what both of you have said. I mean, trust your PPE. And one of the issues that's come out is, are people well enough trained in using PPE? In some hospitals, for example, they've set up PPE coaches to watch people and guide people through the procedure to make sure they're doing it correctly. The biggest risk with PPE is actually when you're removing it afterwards. That's the highest risk time to get infected. So not trust your PPE, but make sure you've had adequate training. And if you're not confident about the training, ask for more training, retraining, supervision. I would say those things are really important. I would add, speak out to management of your observations and concerns. You know what's going on the ground. They may not be aware of it. There may be things that they can do to make things safer and ease things psychologically. And I think the final thing I would add is many of you have probably been hearing about psychological first aid recently. And I think trying to get some training yourself in psychological first aid, understanding what the principles are, because they can guide you to helping take care of yourself and helping your colleagues, helping identify signs that they might be having psychological distress and knowing how to support them.
If I can add something to that.
Yeah.
If I go back to my very first first aid course, the first thing you have to do is safety for yourself, and that's what we do on any scene. If you get hurt, if you get injured, you can't help anybody else after. So take care of yourself first, your partners, your colleague after, and not to quote, and I know this may sound weird, but there is no emergency in a pandemic. You got to take the time to take care of yourself.
Next question I want to ask is about the differences in SARS and COVID with the social media presence, because of course social media has really exploded since the time of SARS. Do you think that the social media has helped the situation by perhaps spreading good information about what to do or how to help people? I think it's been a hindrance. What are your thoughts on that? I'm going to start with Dominic on this one, since he's smiling.
Well, I would say both. It's good and it's bad. The good part is it's helped people reach. If I use like our peer support team here, you can reach to people in isolation. Back in 2003, I didn't even own a cell phone. So, it was a lot harder to reach people. On the other hand, you get all these, misinformation, people that just retweet or resend information without confirming. So, you got to take everything with a grain of salt. I'm not the biggest fan of social media, but it can have some good aspect when it needs to reach people in isolation.
Scott, what are your thoughts on that?
I think Dominic said it all, but yeah, basically, like, we just didn't know what was happening, but sometimes, ignorance is bliss. But at the same time, it would have been so helpful to have some solid, concrete information and direction from not just media, but from also even just from the hospital itself or from the government. And now with Facebook and all these other social media and the TV and CNN, and CP24, whatever, it's just almost overload, and I think that can create just as much anxiety in people with no information. I guess it all depends on the type of person you are. Too much information is going to cause you stress, or not enough, or it could be a combination of both.
Ken, any thoughts on that?
I agree with both Dominic and Scott. I think that it's very helpful for reaching isolated people or people who are in quarantine and so on. I think that's very useful. We know that not having social media didn't stop misinformation and stigma from happening during SARS, so that can happen anyway. I find one of the big differences is trying to filter through the massive volumes of information. How do you find something that's reliable? How do you strain out all of what's unreliable? Even just within a hospital email system, there's far too much being circulated, and picking out what's essential and what you need to pay attention to, I find really difficult.
All right, so I'm going to kind of bring us down to our wrap-up question, which is, what are the challenges that you're experiencing with COVID-19? that are different or unexpected compared to SARS? And Scott, I'm going to start with you on that one.
I work in a far north Indigenous community, so I have to quarantine a full 2 weeks from from everybody before I come up into this environment. I find that was extremely difficult, but it's maybe not for the reasons you might think. I have grandchildren. I couldn't see them, so it was very difficult. But even at that, I couldn't go to the store. I haven't been to a store in over 3 months. Those kind of things. And wearing the mask also is causing me a little bit of difficulty because I'm asthmatic. I had SARS and I had a heart attack, and that's another thing you don't know. But anyway, so I'm at a higher risk for getting COVID, or maybe not even, if I get it, not surviving. So those are the things that are kind of weigh on my mind. But even just wearing the mask is kind of difficult to breathe, and it's a little bit, I can't say, triggering, but maybe it is triggering. I'm not sure.
Dominic, your thoughts?
I'm in a different position right now. I'm not really doing the 911 calls, so that's a little bit different for me. But the mask, like Scott was saying, every time I put an N95, it brings me back to SARS, like it's instantly. But otherwise, I don't see any other, nothing that pops up to mind right now, sorry.
And any thoughts on that?
Well, my own situation is quite different as well. Rather than being frontline in a hospital, I'm what's now sometimes called a sideliner rather than a frontliner, sort of working remotely. I think that a lot of it, in my mind, has to do with just the different course this has taken. SARS, you might have thought of as a middle distance run. This is going to be a marathon. It's going to go on for a long time. It's much more widespread socially. There are the conflicting social factors about what's the priority. Is the priority infection control and saving lives, or is the priority the economy? And there's a lot of tension about that. That it was short enough and focused enough during SARS that those issues didn't come out the same way. To me, that's the big difference.
Actually,
sorry, go ahead, Dominic.
I was just gonna say, and that might just be my perception, but during SARS, especially after the first wave, I got the feeling that they wanted to reopen Toronto a little bit sooner, because Toronto was hurting. There was no tourists, there was nothing. Now everyone's in the same boat. So I think that's kind of helped a little bit. It wasn't just isolated to Toronto. COVID is not,
I'm just going to allow you each a final thought. I just want you to consider what's one lesson you learned from SARS that you would like us to be using going forward for any kind of pandemic, including COVID-19, but just one lesson that's you feel is the most important. So Scott, I'll start with you.
That's a difficult question. I guess be as healthy as you can be in normal times. Be diligent, and so make sure that you're as healthy as you can be, because you never know what's going to come along the line. COVID comes along, you're not healthy, now something like this happens. You so try to stay as healthy as you can, and be diligent about social distancing, and your PPE. Sorry, I don't know. I'm sure there's more, but
that's great, Scott. Thank you so much. Dominic, your thought?
Like they've been saying, wash your hands. That's the biggest issue. Before PPE, before masks, before anything, wash your hands. Be mindful of what you touch, what you do. Maybe for, I don't know, our government or even above organizations, we know these things are, it cycles, they come back, don't wait. You know, next time we see something and, you know, we've known it was in China months ago, start planning. With travel, it's, you know, China is only a few hours flight away, any other country. So don't wait for it to be here, plan a little bit before.
So circling back briefly to my presentation, so one of the things we saw with SARS was that it caused a lot of stress, that between a third and half the people showed very significant clinical signs of stress. So the issue, I think, is how to try to help people with that, how to build resilience in healthcare workers and frontline staff, and how for our organizations and leadership to function to help promote resilience. Some of the references that you saw there will have some really good thoughts about how to do that, how to foster both individual resilience and provide the kind of leadership and the way the organization can work to support workers so that they can continue to work in these stressful situations.
Can I make another? Oh, I have one more comment.
Yeah, one more comment. Scott, go ahead.
I'm sorry. This is the main thing I learned. Learn how to slow down and go learn how to smell the roses. Like, that's the main thing. Like, I appreciate my life so much more now. It's slow down, enjoy your life. Don't be overstressed. But that's the one thing I really learned. Appreciate what we have. I'm sorry to add that, but
That's great. Thank you for that, Scott. I appreciate it. So I want to thank all of you for coming today and sharing your personal experiences. And I want to remind everyone that a survey about this town hall will appear after the session, and a copy of the video will be emailed to all attendees tomorrow. Again, CIPSRT does not have permission to share the PowerPoint presentation, so you can please contact the individual presenter if you have questions. Our next town hall is going to be a special one on Monday, June the 22nd. This town hall is being held in partnerships with Correctional Service Canada, and it's titled Self-Care During Times of Crisis and Change. Registration link will be sent with today's video tomorrow. Again, thank you to my panelists, and to everyone out there, take care and stay safe.
thank you.
Thank you.